Thank you. I'd like to thank the organizers for organizing this great meeting. And I'd also like to thank them for inviting me to talk here. I'd also like to thank the speakers so far today who have set the stage very well for my talk. Thank you for doing most of the work for me. And so my talk is going to be on doing an assessment of some deep learning denoising that we've done in SPECT-Myocardial Perfusion images. And then I'm going to go through that pretty quick because then I'm going to have the second half of the talk with my colleague from UMass, Dr. Yuan Chen, and she's going to be talking using deep learning to estimate a data-driven surrogate for respiratory motion, so we can use that to correct list mode studies. So, oops, one tap is enough. Don't get impatient. Okay, there we go. Okay, so here's my disclosures, the NIH grants that supported our work. And my colleagues who did all the work, including the physician observers we had and the studies I'm going to be talking about. And the motivation for the work came about, well, starting back in like 2009, the NCRP put out a report analyzing the change in the cumulative effective dose to the US population from the early 80s up to 2006. And there was the surprise that due to medical applications had gone up tremendously. The biggest chunk of that increase was for CT. Sorry, I really didn't drink a lot last night, but the mouse is having a hard time getting over here. Wow, what a sobriety test. I don't know if it's doing that for you, but okay. Well, that moves pretty good. The one down here is really, so I shouldn't watch this one. I'm going to watch that. Yeah, this is pretty delayed. Okay, because I was moving it. I'd move it and then it'd come. Okay. Yeah, I think, my God, I really didn't drink that much. Okay. So anyways, as we can see, and I'm going to look up here now. Yeah, so about half of the whole increase was due to CT, and about a quarter was nuclear medicine. Of the nuclear medicine, PET and SPECT, let's say, of the SPECT portion, a lot of it was due to myocardial perfusion SPECT imaging. So that was their motivation. And we developed some grants that looked at what we could do to improve the images on the basis of doing, standard things in iterative reconstruction, like attenuation correction, scatter correction, modeling distance-dependent resolution. But of interest here is that in the later phases of this work, we've gone on to taking a look at DL denoising. And so our challenge here is to see if we can decrease the either administered activity or time or some combination of them by a factor of 2 to even 8 with DL denoising, and still do closer to the full dose than we get with our 3D Gaussian filtering that we've been using so far. And we did a task-based assessment of this, as I said, based upon the work of Terry Barrett and many other people. And also, this is now put out by a committee of the Society of Nuclear Medicine, looking at artificial intelligence and its how to make claims as to what it can achieve. Here's the population here. And if you'll notice that our organizer is in this list. So I congratulate him. But I want to point this out because a lot of you probably don't read the Journal of Nuclear Medicine. And you may not have come across this article, but it's a really good article and gives you a great idea how to do task performance studies and other metrics to use and what kind of claims you can make based upon the types of evaluations that you've done. So having set up that way, let's go up here and take a look at this. So we're going to do a task-based assessment. And to do that, we're going to take a look at creating studies that are lower in counts than the full dose. For that, we acquired a large number of list mode clinical studies. And we can make lower dose ones just by going through the list and coming to every event. And let's say if I want to decrease it to 50%, I put a 50-50 probability on if I'm going to keep the count or not. And from that, I can make a number of noise realizations if I want to on that basis. Okay. And also, I want to make sure I know the truth as to whether there's a lesion there or not. So we took studies that were read as normal. And to them, we added, based upon some work that was done on a PhD thesis over in, I think it was Sweden, back in 1990. They gave us a good idea of where these lesions occur. If you have a lesion in a certain artery in the heart, where the lesion should show up. So we use that to try to find the territories, and the extent and size were varied. So they gave us a set of populations of images of known truth. And we then use those to go out and define how we should do the iterative reconstruction, the number of iterations, and the sigma of the 3D Gaussian post-filtering we were using. And we picked the peak value as being the one that we would use to do the iterative reconstruction. And we did studies, and it seemed to indicate that those, by optimizing it and doing the iterative attenuation, correction, scatter, resolution, we could, improve the areas under the ROC curves compared to filtered back projection. Okay, so then the deep learning. Here's our deep learning strategy. This was published in Transactions in Medical Imaging back in 2020. And probably pretty standard ways of doing it in terms of setting up with the size. We pulled out of the study a cube around the heart, which was 42 by 42 by 21. And we broke it up into patches. We used a convolutional autoencoders with 3 by 3 by 3. And probably the most important thing to point out here is that our loss function was the mean squared error. And we'll come back to that in a little bit. And for this, we wound up having a population of 930 clinical studies that we had acquired in list mode. We took 740 of them. It was a mix of normals and abnormals, and we used those to do the training. That left us 190. We needed some of those to set up polar maps to do part of the analysis we're going to do. And that left us 126 we could do to do the testing with. Okay. And so when we wanted to do the testing, the criterion that we're going to use, okay, well, first, here's the methods. We're going to come look at the full dose, optimized with all of our reconstruction methods in there. And then we went down to a quarter dose with the Gaussian and DL, and then an eighth with the Gaussian DL. We were going to have these studies read over the web because this work was done, well, COVID was still around. And so instead of having the physicians come into our labs, we allowed them to do it at their own site. We did some tests using the SMPTE test pattern to make sure that their monitor had the appropriate contrast levels set at the low and high end. Once they passed that, then they could do the studies. We had them read 10 different sets for the 5 different types of readings. So each set was read in 2 different sets of 63 cases. So a total of 126 altogether. We have a training set that was read before all of this. That was part of those images, and the extra 60 such images that we had for polar maps. So we used those also for training sets. And at the beginning of each study, we had them read 7 training sets. In the training sets, they got feedback as to whether it was normal or abnormal, and if it was abnormal, where the lesion was. The order of the sets being read was put or randomized. The studies within each set was randomized. So if somebody came back and read the set again, they wouldn't see them in the same order. Again, to try and stop learning, well, I saw this one, I know the next one's going to be that way. And we did an analysis using the Lab MRMC software from the University of Chicago. This does an analysis of both the multi-reader situation, because we're going to have 6 clinical readers in here, and the multi-test case. So what we used as our metric was the total perfusion deficit, or TPD. And that uses the polar map and normals to give the system an idea of what normal should look like, and then compares the polar map of your processed image to that. And on that basis comes up with a numerical metric of what the probability of the patient's abnormal. And we use that as our clinical model observer to do the optimizations in the past, and here we're using it to look at these studies. And it looks like we have a pretty good indication that there is no statistical difference between the first three, which is the full Gaussian, the quarter Gaussian, and the quarter DL. And in fact, there's maybe even a hint that the DL is a little bit better than the Gaussian. But when we went from a quarter dose down to an eighth dose, now we have a statistically significant difference, although there's still an indication that DL is a little bit better. If we go on to the 6 clinical observers, however, we get a different picture. First of all, the full dose is statistically different from all the other categories. Secondly, we no longer have any indication that DL is better. In fact, at the lower end, it is statistically different from the other 3 in front of it. So at the 1/8 DL, you're down being statistically different from these 3. Well, between these, there is no difference. Okay. So our clinical model observer didn't really wind up being predictive of what the actual clinical observers did, even though we found it to work fairly well in the past. What might have happened? Well, here's some example images. So here's where we added the lesion. These are short axis slices. This is your horizontal long axis and your vertical long axis. You can see where the lesion was added here. Here's the polar map I spoke about. This is like you take the Earth as a globe and you turn it into a flat map. You take the wall of the heart and you squash it down to a flat map. That's what the polar map is. So we have the polar map and we have our lesion sitting here. And you can see that here's the full dose, then here's the quarter and the 1/8 Gaussian, and things are definitely getting noisier, especially when you get down to 1/8. And yeah, okay. So you take a look at the DL and you notice that it's smoother. The wall is smoother, but we're losing contrast. So numerically, we have the feeling that, well, okay, the uniformity got better and the contrast went down, but because the uniformity was better, then the TPD could figure that out and it wasn't as sensitive to the whole thing. Okay, so another problem we came up with is the idea that we really didn't use the TPD to optimize it. We just picked our target that we had and trained against it. So maybe we should try a different way of doing this whole thing. Over the last year or so, or less actually, we've been trying some different ways to do this. We've taken a look at saying, well, let's go for a higher resolution target because we're losing some resolution in the training. And we found with limited PhD observer, not MD observers, that seems to be better. We also took a look at, well, gee, in the training set, we had a limited number of lesions. Let's add some more lesions to the training set and see what happens. And that tended to give us better results. We had some other things we tried. But basically, I'm sort of out of time. And I'll say that I've learned some things here yesterday that we're going to go back and try. So the Gaussian diffusion seems interesting for this, perhaps. And let's go on to the next speaker. Should have moved this over. I guess my slides like you can show.
It doesn't work.
Keep going. Hit the right arrow. Oh, okay.
Yeah, so as Dr. Kim mentioned that besides working on SPECT denoising, we also worked on using deep learning for respiratory motion correction in cardiac SPECT imaging. A bit of introduction here. So respiratory motion is one of the 3 causes for motion artifacts. And it's involuntary, meaning that it's impossible for patients to stop breathing for 20 minutes of scanning time. And the magnitude can be large, such as more than 20 millimeter, which could really lead to image artifacts and misdiagnosis. Although the motion itself is in 3D space, the respiratory motion is mainly along the y-axis as shown here in the figure. This is because the diaphragm is moving up and down for respiration. And the effect of this respiratory motion on SPECT images is also from the image shown here is a blurring of the images and intensity reduction, especially for the anterior and inferior portion of the heart wall. To understand how the respiratory motion really affects our data, so we'll first examine the data acquisition process. In most SPECT systems that we do step and shoot mode, that means we first scan at one angle, and at the next time point, the camera heads are rotated to scan at angle 2 and so on. But during this process, the heart moves up and down. So this makes that for each projection angle, it is a mixture of respiratory states with heart at different locations. But if we were given a signal like that, we can then separate the different respiratory states apart by, for instance, based on the amplitude of the signal. For instance, here we can pick one part of the signal. This is symbolized the large displacement of the heart within the respiratory cycle. And correspondingly, LIST-mode data that falls within this time frames can be grouped together or say placed into the same bin. And later on, we can do an image reconstruction using the data here because they are now from the same respiratory bin. And more importantly, they're now this data covers all projection angles, making an image reconstruction possible for SPECT. And similarly, we can repeat this procedure for other parts of the respiratory cycle. And then later on, we can do, for instance, image registrations to compensate for the motions between different states. So now we just talked about if we were given a signal like this, describe some heart movement, then we can do motion correction. But the thing is, how can we achieve a signal that describes a heart movement over time? To get a signal, one way is to use external motion tracking devices, as shown here, that is mounted on the wall. So this is the VTS cameras. VTS is short for Visual Tracking System. That is infrared cameras that can accurately track the motion. And in our study, we mounted these cameras in the scanning room and we use it as a reference standard. But using external devices have these drawbacks like technology's time and operational complications in clinical. So data-driven method that can estimate the motion from the SPECT data itself is being investigated. We have previously also tried to use the center of mass method. The brief idea of center of mass is that instead of getting one projection image at each projection angle, we separate the projection data, which was acquired in LIST mode, into small time intervals to have many short frames. And then from these short frames, we can track the center of mass in each short frames to get a signal. And to also explain a work that we recently published using this center of mass study. So this is how a projection image looks like at one projection angle. So from this projection image, which is acquired in LIST mode for 20 seconds, we separate into short frames. And then from the short frames, we get the heart and then calculate the center of mass within the heart region and then track the shift of the center of mass in y direction over these short frames. Although this method is like very promising, but it actually has a lot of limitations, especially when applied to real patient studies. For instance, we need to segment a heart mask in the projection space, and also it has compromised accuracies in a lot of cases. So this brings us to the work here, that is to use deep learning to estimate the respiratory signal from the SPECT projection data. So basically, we are not, from the short frames of the projections, we do not pre-calculate a center of mass to define the motion. We input the short frames of the projection data to the network and let the network learn to predict the signal. And for this, we use the VTS, which is an infrared camera, external devices, as the target for training of the network. And we test it on a total number of 900 patients, among which 300 is for testing and the others for training and validation. And to briefly show some results, as we compared the different signals. We used the traditional center of mass and DL signal compared to our reference standard, the VTS camera signal, to calculate the Pearson's correlation coefficient for each patient. And this is a scatter plot of the coefficient for all the 300 test patients for center of mass method. And then this is for the DL results and the histograms of two methods. And when we calculate mean, we see that the correlation for center of mass is only 0.7. And when we use DL to learn this information, the correlation increased to 0.9. And when we apply this signal for attenuation correction on SPECT images, we also see that, so two examples showing here, we see that when applying a correction, you see a better definition of the heart wall that deep blurs. And when we look at the polar maps, the DL method gets more similar results compared to our reference standard VTS method than the center of mass. More analysis that is done on the polar maps. So this is mean polar map for all the 300 patients for each method, because it's difficult to assess the difference from this mean polar map. Then we calculate the difference polar map, that is simply by subtracting the no correction polar map. So the red means you get an increased intensity, blue means you get a reduced intensity. We see that when we are using our reference VTS method, you see an increased uptake in the anterior and inferior portion of the heart wall. This is what we anticipate when we apply a motion correction, because that is a part that gets blurred and reduced intensity. And when comparing the DL method with BTS, that's visually that the DL gets the most close results to our reference VTS. So this is actually the same, but the difference is expressed in percentage. So a bit of summary of this work, like we still have a lot of limitations, like we are only using computerized image-based metrics to assess our strategy. And it would be nice to use human observers to do more clinical interpretation of the results. And also, we are only based on data from a single scanner, single clinical site. So the generalization probability could be better validated. And but as a feasibility study, we show that it's possible to use DL to really extract this motion information from the projection image and then do respiratory motion correction. And it can help reduce the artifacts and achieve similar or accurate quantification as what we observed using the external infrared camera approach. And this concludes my portion of the presentation. Thank you for the attention.